Hey everybody, and welcome back to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm your host, Kylie Como. I'm the legal nurse consultant here at Shane Smith Law, and today I'm joined again by our friend Dr. Devin Gaston, board-certified functional neurologist, CEO, and founder of Passport to Health. Dr. Gaston, good to see you again today.
It's great to see you. It's great to be on the show.
So again, anybody that's tuned in, or if you're new to us, we love to talk about all things traumatic brain injury. So again, let's get to it with Dr. Gaston. I'd like for you to kind of step back another step to go back to that circadian rhythm. You see those disturbances quite a bit, with traumatic brain injury, concussions, etc. How frequently do you see that? Just to validate that for our listeners, those disturbances, and then what interventions might you try to restore that circadian alignment, while supporting that overall neural recovery?
There's a couple of different ways to look at it. So, I see this all the time that no head trauma is the same. And it's not even the same. Like if you have one person, we're not exactly the same in, different decades of life. Our stresses, our exposures. So you could have a head trauma 10 years ago, have a head trauma now, and it could be a different experience. Okay. So I do want to point that one out. And at the same time, it's also, there's an element of things being cumulative too. Okay.
Mm-hmm.
So if you've got someone who's got a history of multiple head traumas and are having circadian rhythm disruptions, then I'm going to definitely go and check the hormones. So if I've got someone who has, and it also depends on the type. So if someone's like waking up all the time in the middle of the night, and it's all like, is it due to pain? Is it due to nausea? Nausea is a common one. So if you've got, especially that problem where like the brain is trusting the eye information versus the ear information, something to that effect. If someone had a predilection for vertigo prior, where there's naturally a weakness in processing, when they get into bed and they're laying down flat and the brain's no longer receiving input about posturally where they are, in a way it's harder for the brain to kind of gate this excess information that it's taking in, and it's not receiving anything. So one thing that you can do, so this is really, really helpful, and I don't want to get into the weeds too much with this, but is, really like having a patient prop up their head at 45 degrees, especially in the presence if they have nausea with their head trauma. It could be the nausea that's keeping them awake. The other aspect to that is going back to blood sugar. Do they have enough fuel to keep them asleep throughout the night? That can happen, right? You can wake up, if you go low blood sugar, your body's going to release adrenaline to try and meet that demand of increase in blood sugar. And that adrenaline will wake you up in the middle of the night. So a lot of times people will wake up between even a little bit later, like 3:30, 4 o'clock in the morning. And they're like, I'm just wide awake. And I'm like, well, it could be your body is physically waking you up because it's like, bro, I got to eat. So there's that. If already having a hard time falling asleep, we've got to take a look at sleep hygiene. And that really does, that goes back to circadian rhythm, because that is a real thing. That, blue light emitting from screens, that frequency is literally designed to keep you awake. So if you're staring at something that's literally designed to keep you awake, what do you think is going to happen? It's going to keep you awake. So avoid, I have people avoid any sort of cognitive anything. I'm like, I don't want you using your brain past 6 p.m. Like, if you got to get to emails, sorry, do your emails in the morning. Like, you just can't. It's like, you got to protect your brain of what you're allowing it to do, but, what you're exposing it to. I mentioned a couple different types of sleep disturbances. And then, of course, it's also a stressful situation in general, which, you can actually stress your adrenals. That does happen. And so there's things that you can do to support the adrenals. From a functional med standpoint, there's some creams, there's some pills, there's all sorts of, there's even food strategies. So one thing I'll tell patients is, like, if you were waking up in the middle of the night, eat as long as you're not allergic, not, on a low histamine diet or something like that. Have half of an avocado, right? Half of an avocado before bed. Don't be worried about getting fat. Don't be worried about any of that stuff. Have half an avocado. And that can be enough energy to sustain you throughout the week. Have a small handful of that. Something fat, right? Healthy fat. That can really take care of a lot. Another thing that's really helpful is magnesium. So another reason people can stay awake is that their brains are literally overstimulated and they're overfiring. And so magnesium, there's two special forms. There's magnesium bisglycinate, and there's also L-threonate. L-threonate is my favorite.
Okay.
And it's used in psychiatric, settings all the time for similar things, getting the brain to calm down. Don't have it over fire. There are some studies that came out recently regarding the treatment of PTSD from, a nutraceutical chemical approach, simply using magnesium. So the particular sleep disorder really matters. Of course, we want, when necessary, if you got someone, running around in the fog all the time during the day, we do want to think, is there a sleep apnea thing going on? Because you can develop obstructive sleep apneas as a result of head trauma. Just it's the same neurological control. Lower brainstem controls the palate, and so the palate can fall when you sleep. Most people, and a lot of people actually, don't think about that really is, it's not just like this, it's not something that just needs splinting. We'll just put it that way. Okay. It's responsive, it's neurological control.
As you're talking, it just made me, again, kind of, you validate, you reaffirm how just so easy it can be to, I would see how easy it could be, rather, to be misdiagnosed, as we kind of talked about earlier, and then just start chasing down the wrong rabbit trail and never get any better when the fix is something completely else, because the problem is somewhere else. So again, very important for our listeners to really, open their horizons a little bit and ask those kind of questions when they're sitting with their providers. You mentioned dizziness and vertigo. So patients, our clients here at Shane Smith Law, a lot of them come to us, and one of the biggest symptoms we see is dizziness, vertigo. How do you clinically distinguish like a peripheral vertigo versus like a central dizziness with mild TBI, and why is this critical for treatment?
So there's a couple of different ways to do this. One is through, so what we utilize in office is called digital force plate posturography. So what was traditionally known as CAPS back in the day. So what I'm describing is this testing situation where you stand on a device, and you're gonna stand with your eyes open, your eyes closed, and then you're gonna stand on like a foam pad with your eyes open, eyes closed. And we're able to assess different contributions to postural control as it relates to balance. Okay. And so in these different situations, like for example, if you're standing normally, and then you close your eyes and then you develop this massive sway pattern, that's not a good thing. So, and quite actually, honestly, a lot of people, I'll do this test and they're like, I had no idea I was swaying. I had no idea. They may just present as really bad anxiety, or they're like, oh yeah, I had vertigo, but I had that 2 weeks ago. Like, okay, so if it's a peripheral vertigo, so meaning like if it's like inner ear base, which it could be, you can definitely have a BPPV. Yes, it could be a crystal thing, but if you're redoing an Epley maneuver 10 times, it ain't a crystal thing. And I see that all the time, and it's really kind of a pet peeve of mine, because an Epley maneuver has a 90% success rate after the second maneuver. You're still doing it, you missed the reason, okay? So, okay, and there's a big difference between whirling vertigo, which tends to be more truly vestibular, versus a sense of disequilibrium where they feel like they're on a boat, or they feel like they can't feel their feet, or walking on a suspension bridge, or there are all these different scenarios. You can have visual motion challenges with either one of those situations, but it does tend to be more common with inner ear. But then the ocular motor problems. Okay, so if you just have like a crystal issue in the ear, it's very predictable what's going to show up in the eyes. So if you go into an EENT office, they're going to do something called a VNG, and they'll do something called a Dix Hall pipe. And so they have you like wear these goggles, and then they'll like bring you back kind of quickly. They go back at an angle because they want to see how your sensors in your inner ear are relaying information. And we have reflexes with all of this stuff. So whatever your ear is doing, your eye is going to do something in response. Okay? Just some of these, again, the names of it, vestibular ocular reflex, there's a couple different reflexes, which that's a big thing that I focus on. And if that's not intact, of course your eyes aren't going to work. Of course you're going to be dizzy. Your brain's going to feel like you're falling off the planet. And then you have those symptoms because your brain literally thinks you're falling off the planet. So you don't tend to get you'll have a very specific nystagmus as far as like if it's a crystal thing in one specific direction. Okay, it's not going to be all over the place. It's when you're doing the H pattern, like when you get checked in the ER or anything like that, you shouldn't really have issues with that. Okay, you should be able to focus and hold your gaze on something and turn your head and not get nauseous. There's all these different neurological tests, like just good old-fashioned neurological tests, but then there's also these fancy digital devices that they give us insight. But regardless, it's really predictable. The patient's eyes are going to tell you. So there is some crossover between different fields, between neurology and EENT, and frankly, it's not even really. I mean, of course, there's overlap. It's the brain, and it's different. Like us as I don't know, Western medicine, we decided to compartmentalize everything, but when it comes to brain injury, you've got a lot of things that cross over. So.
Well, you said it. The brain is our supercomputer. It does control everything. So trying to compartmentalize the brain seems like a kind of a foolish endeavor. So I'm glad we're breaking out of that box, and we have champions like yourself to kind of hopefully lead the way into some different thinking. From your experience, Dr. Gaskin, kind of where are we? Whether you're talking in clinical practices, administrative type settings, or even like from an educational context, where are we with contributing to mild TBI being overlooked oftentimes in these personal injury cases?
I will quote a study that came out in 2020, and they did retrospective. It's like 2,000 people or something looking at ER admissions for vertigo. So just for vertigo, right? And I mention this because disequilibrium in vertigo is so common with MTBI. It really is, because there's so many things that contribute and can go wrong. It's like 60% of the time it works every time. 60% of the time the ER was effective at diagnosing a benign vertigo.
Nice.
30% of the time they were able to diagnose something that was of central origin, meaning something that could potentially kill you or be chronic. Those aren't good stats.
No.
First of all, I myself, I literally just started keeping track. January 1 of 2023, we have successfully saved the lives of 13 individuals.
Wow. Between
strokes, post-traumatic arachnoid cysts that were ruled as incidental findings and benign. 3 of those, this stuff gets misfilled off. I'm going to say they're not very successful at diagnosing. And most of the time, like, oh, your MRI is clear. I can't tell you how often that there's not even like, hey, you should follow up with your primary care. You should follow up with your neurologist.
Yes.
I've had people go in and they do x-rays of the neck, and they're not doing imaging. So I'm like, I'm doing imaging all the time. And I order spec imaging all the time. All this stuff, it's helpful for a case, but it's also helpful for that patient to know, hey, by the way, you have this deficit. And I think that it's a responsibility for practitioners to educate their patients, especially on, you don't want to freak them out, but it's like, hey, you have a weakness here.
Yeah.
And even though, and honestly, with the work that we do, we get people asymptomatic. Well, most of our head trauma patients really do recover, and they're able to return to driving and work and live fulfilling lives. We've had patients of all different levels. We've had patients that was in a coma for 8 months.
Wow.
So, yeah, and he's not driving, but he wasn't able to talk, and now he's on dating sites. So that's a little thing. So
there you go.
Proud of that one. I'm not very happy with as far as how it's been handled, but I do have to say I do believe the tide is changing.
Yes.
Because of actually I think law firms are a big part of this, because you guys are practicing doctors to be able to argue a case for a patient to say, yeah, there is head trauma. This person is going to have some sort of deficiency for the rest of their life. Y'all pretty much have to be doctors, and frankly, I think you're better than half the ER doctors. So I don't mean to be discouraging. I don't know what else to say. So, and this is just respected to my region. I can't say that. I'm sure there's other regions of the country, but since I had a stroke 3 years ago and I did a tour of every hospital facility here, I did do a medical audit of the region, and it wasn't good. So, It's changing. There's a lot of, AI is really going to make a huge difference in the States, especially with medical errors as it relates to imaging.
Yes.
So hopefully that stuff won't get missed anymore due to biases and not ordering things because of someone's age.
Yes.
Or, whatever, right? So I think that's going to make a big difference. The focus in biotech and in neurological health, especially in a post-COVID world, I think is also helping, because there's a lot of people that agree that say, post-COVID or long-haul COVID is actually chemical concussion and you treat it essentially the same way.
Yes.
And so I feel that there's a lot of different things culturally that they're converging to bring the awareness that head trauma really is, because it's so underreported. But there's so many different failures within the system that someone could fall in those cracks. So, but we're getting there. I think we're getting there.
I agree, and so much of what you said, I just couldn't agree more with. I think the old way of approaching things, medicine, healthcare, that siloed approach, I do agree. You're starting to see that crumble. I think out of necessity. It's a much faster moving world. People are much more aware and are getting educated about these issues themselves, lay people I'm speaking of. So I think healthcare, medicine has had to respond to that. So that's great. I agree. It should move faster. I especially like how you shouted out law firms. Being a registered nurse, I'm embedded inside a law firm. I work for a law firm, and it's my job to do exactly what you're doing, is to find those holes and to try to help our clients understand what may be being missed, and get them to providers who frankly know what they're doing, like yourselves. So I do appreciate the recognition there. I 100% agree. Dr. Gaston, kind of as we close it out, I really would like to pull everything together by really drawing from your kind of dual perspective as a clinician and a patient, and ask, what key reforms, if you could have anything, what key reforms would you like to see implemented to improve, traumatic brain injury diagnoses and then the care of these patients within that personal injury context?
Okay, I probably would have to, I'd say a couple of things. One would be the inclusion of blood work. Mm-hmm. Because there's, when you're typically working with a patient, a law firm is going to, refer out to, or help guide, right, that process. Physical therapy, chiropractic, a lot of these hands-on physical medicines are covered. Mm-hmm. Serum testing, the functional aspect that really can contribute to this protracted recovery, I don't believe is really included. And so I wish that, I hope that eventually that will be more common practice. Yeah. Honestly, we just need more providers in the space, period. Yeah. So in our region, there's three, for the most part, there's 3 head trauma facilities, and we make up 1/3 of it. And so for part of the time that I was down injured, there were people that were not getting care, and there was an access to care issue. And we're still in an access to care situation. Yes. So I don't know. I don't know if there's something else that needs to change as far as med pay, mm-hmm. with covering some of these advanced services.
Yes.
Because there are a number. I'm very fortunate. I have a cash practice for neurodegenerative conditions mm-hmm. outside of personal injury. Not everyone is set up that way. A lot of people are on a reimbursement schedule with insurance. Yes. And so if insurance is still dictating care to some level. Yes. And so I wish that things were set up so that other therapies, newer therapies that aren't necessarily, covered by Medicare for reimbursement, which does translate over. They're really the ones that set reimbursement schedules. I wish that didn't play a role, but this is the real world. So someone's got a solution for that. I don't know if I do.
I mean, I think you're on the right track. I think we just need to get the right people to listen and consider and step outside of the comfort zone, so to speak. I appreciate your calling out of the blood testing. We're starting to see more of that from the few providers we have that our clients do deal with that are utilizing that. The DTI you mentioned earlier, the diffuse tensor imaging, amazing tool, but we're here in the Georgia, North Carolina mainly. Our clients have had to travel to Texas when they find that there's a provider there. So I mean, it's out there. It's just not very prevalent. And so yeah, I would love to see more of that. To your point, really do appreciate that.
Yeah, actually, I guess that's the other thing, to make sure that that there's family counseling.
Mm-hmm.
So around head trauma. So for a short period of time, just by the nature of where our practice is located, we were neighbors with a very large, therapy facility,
Mm-hmm.
for mental health facility. At the time they were expanding, they needed additional space, so we actually had in-house therapy at the same time. There's because it is the invisible injury that people don't see, and there's so many ripples outward of how it affects family dynamics and relationships and work, and it's not even so much even in just that time of injury. It's like that time of injury may be 6 months, but then the ramifications can be years long.
Mm-hmm.
So I think having some sort of regular support that just naturally comes with it, I think would be really cool. Again, that comes down to just getting, really making things more interdisciplinary.
Yes.
I just give a shout out to anyone who's struggling with head trauma or stroke. Know that there's so many therapies that are out there. It's amazing. There's so much stuff, and I'm living proof of it. I mean, literally, I had to actually, dragging my leg, diagnose my own stroke. I'm not even kidding about that. And rehab my own stroke before I even saw a neurologist. It took 3 years to get a neurologist.
That's crazy.
So I've been standing, our clinic has been standing in that gap at the same time. So don't give up, get the help that you need, reach out to trusted people, and it does take a freaking community. It takes a village. So especially with something like head trauma, know your people, have your people, and it's short term in most cases.
That's right. All right, everybody, that's going to do it for another great episode of Mind Matters, Navigating Head Injuries and Concussions. Again, I want to thank Dr. Devin Gaston for joining us today to share all of her great expertise and her passion with us. Remember, you can find Dr. Gaston and her team at Passport 2 Health in the El Dorado, California area, as well as going to their webpage, passport2health.co. I hope that our audience has enjoyed this great discussion and is leaving with, again, that sense of appreciation for this exciting field of functional neurology and really that innovative approach to treatment available to anybody struggling with TBI or other complex neurological or autoimmune disorders. Please don't forget to hit that like button and subscribe to our channel to keep up with our latest content, and leave us a comment and let us know what you thought of today's discussion. And again, as always, remember, if you're in pain, call Shane at 980-999-9999. Thanks again.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.